live.
Good morning, everyone. Today, I have a very special privilege of introducing someone. Good morning, everyone. Today, I have a very special privilege of introducing someone who I have followed her career for many years and had been a leader in the field and a mentor to most of us who have been in the field of cardiovascular imaging. Pamela Douglas is a Ursula Geller Professor at Duke University, where she is the director of the Multimodality Imaging Program. She completed her fellowship in cardiology at the University of Pennsylvania, and after that, she had a really incredible career, which included becoming the chief of cardiology at the University of Wisconsin and later on at Duke University. She had prominent leadership roles, being the president of the American Society of Echocardiography and the president of the American College of Cardiology. She had led multiple clinical trials, and one that to me is very special is a PROMISE trial. And the reason why I consider it very special is because Pamela is one of the few people that I have met that had really had a position and was able to entertain the possibility of a new paradigm. Pamela was a pioneer on a stress echo. And when we started with the use of CT coronary angiography, most of the people were in one camp or the other, but Pamela thought that the value of these two technologies had to be investigated. And the PROMISE trial has been paramount in the development of the field that have led to many of the guidelines that are now incorporated. I am sure that Pamela will be touching upon the learning that has occurred over the last 2 decades in the field. And it's a great privilege for us to have you back again talking to Montefiore. Pamela.
Oh, thank you, Mario, so much for that very kind introduction. And what a great pleasure it is to be able to talk to you all this morning. And I hope that the virtual nature of this doesn't take away from the presentation or distract from participation when we get to the Q&A. So the title of my talk is Using Quality Principles to Improve the Evaluation of Patients with Chest Pain. And of course, need to get relationships out of the way. I have only one that is relevant to this presentation, and that's a research grant to my institution from HeartFlow. And I will be, when I talk about HeartFlow data, I will remind you of this. So Dr. Garcia mentioned the PROMISE trial. Maybe the best way to start is to kick off a typical patient. PROMISE was a 10,000 patient trial funded by NIH in people who presented with new onset symptoms that were suspicious for coronary artery disease. And we randomized them to either usual testing with functional testing, stress echo, stress nuclear, there are a few stress ECGs, or CTA as the initial test. And then after that, we just let the care happen however it was supposed to happen. And we were happy at the end of the trial to realize that this was the typical patient that we enrolled. 61 was our average age. We were 53% female. Most common symptom was atypical chest pain. Over half of the patients, these risk factors, not all of them necessarily, but more than 50% obese, more than 50% hypertensive, and so on, hyperlipidemia, smoking, sedentary lifestyle. So strong risk factor burden. The pretest probability of obstructive disease at that time in the guidelines was the Diamond and Forrester score modified by Cath. I'll talk about that a little bit later, but at least a 50-50 chance of having obstructive disease and a 17% risk of a cardiac event in the next 10 years. So this is, I think, what we would all consider a reasonable risk profile for patients that come to us in the office, and we see patients, you all see patients like this every single day, outpatients, and have thought deeply and have established practices about what more you need to know about this patient and what you would do next. And so this talk is about to talk about this. So before we do that, let's just say, where are we now in evaluating stable patients with suspected coronary disease now? And as it has been for over 100 years, cardiovascular disease is the #1 killer. Chest pain is a common presentation. This is a huge number of patients in the US every year, with lots and lots of costs for the testing alone. As it turns out, when we look at the PROMIS population and other populations, obstructive disease is actually fairly unlikely and outcomes without revascularization, which means we're shifting some goals of testing and considering whether current algorithms, and I'll talk about the new chest pain guidelines that were issued last fall, which try to correct for possible over-testing. These new guidelines also introduced CTA as a new class 1 indication in these patients, but also created some additional controversies that I'll talk about. And really what we have now in 2022 is not a universal consensus on initial evaluation test modality or whether or not to test, and some new technology which may offer alternatives. So big population where we still don't have like hard and fast answers. So when you don't have answers, my go-to is always to look for quality. And this is work that I did as president of ACC to try to pull the imaging world together, imagers, health services, researchers, quality gurus, to say, how can we think differently about imaging? Not just how much volume are we doing and how much cost is there, but what value are we getting for our patients? Traditionally, imaging quality is thought about the acquisition and interpretation. But what we decided that we needed to broaden it out on both ends. We really needed to start with the patient, the right patient at the right time, getting the right test. Of course, the test needs to be done well and interpreted well, but the results need to be communicated and incorporated. Otherwise, we're not going to improve patient care. And we don't often think about improved patient care with imaging. We think about our ability to diagnose or sensitivity and specificity, but really we need to get to outcomes when it relates to imaging, because it does have some risks, albeit not the same risks, of course, that an invasive procedure might have, but you can miss disease or you can overdiagnose disease. And so we really need to start with the patient and end up with better outcomes. So let's look at each of these domains now, and that's the structure of the talk. So when we look at the patient domain, first thing we need to determine who actually needs testing. And in all the guidelines, this is through estimating pre-test probability. And what I'll show you in the next few slides is that using the traditional Diamond and Forster that were used for many, many years is grossly overestimates risk. Because this was, as 40 years old now, was based on cohorts in the Cath lab and actually 20% in the autopsy room, and a very, very different state-of-the-art care. No statin, very little aspirin, no ACE inhibitors, poor blood pressure control. And so we don't really want to know what proportion of patients in the Cath lab. We want to know the proportion of patients at the office having a non-invasive test is likelihood. So there have been multiple corrections using contemporary cohorts, properly treated, and CTA data for the prevalence of disease. We've also done work published recently that adding risk factors and further improves prediction of risk. And then I also want to talk a little bit about the impact of changes with the ACC AHA guidelines that came out, which changed our pretest probability. So here's an example of updated pretest probability derivation from the PROMIS trial. We took 4,400 patients with chest pain and looked at their actual anatomy by CT using a generous 50% and also using the same Diamond and Forster category women, different age groups, and then different chest pain types. And what you can see is the CT prevalence is the dark bars, but the Diamond and Forster predicted prevalence is much, much higher in virtually all the groups, significantly higher by 50 to 70% over the old guidelines, which were just replaced last fall. So, for example, all women over 60 have less than 15% pretest probability, regardless of symptoms. And in women over 80 with typical chest pain, that's this group, really cut the risk of disease from 80% to 25%. Very different risk. Men less than 40 for typical angina, that's this group here, were 76%, are now 4%, and atypical now also similarly low at about that same level, down from 34%. So really changes the landscape of how we predict disease. Now, I think we can, not only can we do that, but we can improve on these estimates by for testing. So that shifts things around a little bit. But the strategy in the new guidelines was to change the testing threshold from anybody with disease greater likelihood of 5% to 15%. But maybe we can be better and incorporate clinical information to improve risk prediction. So we partnered with a Danish group, did a machine learning model on over 40,000 patients with validation in 15,000 patients. And we found that adding risk factors or risk factors plus calcium score reduced eligibility for testing, almost half of the patients, and improved accuracy. So here's what the data look like in the AUC curve with the calcium score addition here in red. If we use the new pretest probability numbers and use a testing cut point of less than 5%, only 11 patients, 89% will go for testing. Now in PROMISE, of course, 100% of patients went for testing and 100% of patients in our cohort, in PROMISE cohort, not in the combined cohort, were eligible. If you add risk factors, look at you actually drop by 27% the proportion that need testing just by simply considering clinical information alone. The AUC budges a little bit, but not a lot. But if you add calcium score, or for that matter, prior information about calcium presence on a chest CT, you're now testing less than half the patients, and the AUC is 85%, quite robust. So pretest probability using age, sex, and chest pain alone is a very limited assessment for risk. So let's look, I've been talking to you about the European guidelines, which were published in 2019, which were the unveiling of these new pretest probabilities. They recommended testing everybody greater than 15% pretest probability. In the indeterminate group of 5 to 15%, they recommended using clinical risk with no testing for 5%. And this is the prevalence, expected prevalence or predicted prevalence of disease. He also added this dyspnea column, which I think is very helpful. So no testing in gray zone people, definitely test in the darker green, maybe test in the paler green. Now, in contrast, the AHA guidelines published in October removed chest pain type from pretest probability, and I'm not on the group, so I don't really understand. Instead, substituting the highest number for all three groups. So what they did was, let's take this example that I'm just pointing to with men of 40 to 49. So if they had typical angina, the predicted prevalence of disease is 22%, quite worrisome. On the other hand, if they had non-anginal type chest pain, the predicted 3%, not somebody in whom we want to test. And so by categories together, the new guidelines really hampered, in my view, our ability to discriminate between low and high risk and made everybody quite a bit higher risk. Further, They suggested that you test only those greater than 50%, the very darkest green here, with deferred testing in those with 5 to 15%. So instead of saying, look at clinical risk, as the Europeans did, it said don't test. But then it did have a 2A for considering Cath and risk factors in the text, but not in the recommendation. So actually took the new pre-test probability guidelines and shuffled them around in a way that was a little bit concerning, particularly since there's no data on not testing. Very, very little of that. So in summary, these changes, it removed chest pain characteristics so that overestimates CAD risk with atypical and non-anginal symptoms. Shifting that testing cut point from 5 to 15% dramatically changes the population in whom testing is recommended. As you might expect, this is a lot of the population in this 5 to 15%. And we have in press, in circulation, a paper where we took the new guidelines and applied them to the PROMIS patients. 100% were eligible for testing under the old guidelines when PROMIS was done, and 97% were eligible using the ESE test probability and the ESE cut point of 5%. But shifting to testing in only 15% actually excluded 53% of the PROMIS cohort. So under the new guidelines, compared to the old guidelines, it excluded half of the patients. And most importantly, this was a sex-specific or a sex-stratified change, with immediate testing not recommended anymore in 89% of women in PROMIS and 18% of those. Now, as I said, maybe some of those patients would have other ways of stratifying, but when you look at these new guidelines, women under 60 or men under 40 would never be recommended for immediate testing. And that, I'm sure all of you have seen MIs in people in these age groups, age and sex groups. So that to me is very concerning. When we applied the new guidelines to PROMIS, we found that even excluding half of the patients and 89% of the women, the prevalence, actual prevalence of CAD was still under 10%. So it really didn't identify a high risk, super high risk group, a little bit higher, but not super high. And it, in terms of disease prevalence, and didn't identify a super high clinical risk patients were CVD only 1%. So the value of these changes, I think, needs to be explored a little bit. And we need to figure out, I think, how to improve identifications of those with limited benefit, and is the correct threshold 5 or 15%. And I'm going to show you some other PROMIS data which may help us with testing decisions. But here where we are now in support of deferred testing strategies recommended by the guidelines, you know, obstructive disease is infrequent, event rates are low, revascularization doesn't help much, and that's data from ischemia. There are other ways to identify risk that I've talked about. I think one thing that's really important is that there are excellent preventive and anti-anginal therapies that are available that are underused. Only half of those with a history of hyperlipidemia were on statins in PROMIS. Against a deferred strategy, there's few prospective data, observational or RCT. There is an observational study in Europe called Clarify, which looked at chest pain patients with established CAD, and the majority of those had no events and their chest pain went away at the end of the year. But in terms of those with initial presentation with new, arguably a higher risk group, we have no data, not any. And so it was, in my opinion, again, a bit of a reach for the guidelines to be so strong about this. The cohorts on which reduced testing recommendations were based, like PROMIS. I mean, PROMIS was well cited on this, and people did well in PROMIS. Low risk people did very well, but they were tested. And so their care was informed by testing results. And so we really don't know, for example, if PROMIS had had a no testing arm, what the outcomes would have been in that group. And of course, we always worry about missing left main triple vessel disease, where revascularization can be life-saving. These patients were excluded from ischemia, a randomization from ischemia, and we worry about liability and need for a diagnosis. So let's turn to another study we did from PROMISE, where we tried to identify people with no risk. So virtually all of our risk scores are identifying risk, higher risk. And now let's identify lower risk. And it's not exactly the same thing. So we took all of our CTA patients, and it turns out 27% of them, just over a quarter, had absolutely no plaque, had no events, no calcium. And we thought, how can we create a model to identify these people? And we did, using clinical variables that are available in the office. And the C statistic was a respectful 0.73 here, blue line, compared to Framingham here, and the Diamond and Forster AUC, which of course was for prevalence of CAD in purple. So an improvement over that, and it was been validated in 2 other cohorts with actually a slight improvement in the C statistic in the area under the curve. So we think this is an interesting tool. And so we took it, and this is impressed now on JACC imaging, and say, well, let's look at pretest probability first, and then categorize those folks in that 5 to 15% intermediate range on the basis of the PROMISE low risk score. So a 2-stage assessment. And in fact, 48% of the PROMISE patients were in this testing may be considered group. 42% were in the lowest risk quartile by PROMISE minimal risk score. That's the green field, but 6% were in the highest risk quartile. So we really don't want to not test these folks, and probably these folks as well. And the prevalence of obstructive disease was tightly linked to the quartile. You see here, 10% in the lowest risk quartile versus almost 40% in the highest risk quartile. And so using these 2 tools, the updated pretest probability and the PROMISE minimal risk score, may help to optimize some of the testing decisions. And we compared that. Here's a complicated slide, and use the PROMISE minimal risk score, low risk and high risk. And you see we took, again, this group, I'm sticking with them then in the 40s. The AHA guideline pretest probability risk was 22%. If they were in the lowest risk quartile, it was actually 2%, but 11% in the, sorry, this is actually lowest risk Cath and the highest risk Cath. So you see, you get a really nice separation with actually fairly different numbers from what's in the guidelines. And the same thing is true, for example, to go to women, less than 10% in the guidelines. But if you use PROMISE minimal risk score, you can split that out into 3 or 15%. And that's true all the way through. I won't, this complicated slide, a lot to go over. So that's a lot about the patient. Let's talk about the test. Current stress testing is roughly 80% sensitive and specific. You might argue that PET and CMR is maybe a bit better than that, but for the sake of argument, this is what's used in the guidelines. And unfortunately, neither positive stress nor obstructive CAD on a CTA are good indicators of disease. So let's look at that. So this is stress testing. 80% sensitivity and specificity means that 1 in 5 patients will receive erroneous stress test results, which may lead to additional test time and cost or a missed diagnosis. Whereas only 1 in 10 will have coronary disease. So 90%, 9 of 10 won't have significant coronary disease. 95 of 100 will not need revascularization, and only 1 will have an event. So you can see it's really, to prevent this event is really a needle in a haystack with a not very refined tool with stress testing. And as a result, this leads to a lot of patients going to the Cath lab who turn out to have no obstructive disease. So we published this paper 12 years ago now, and it created an enormous stir. What we did was taking an NCDR, Cath PCI, all elective diagnostic Caths that were being performed to rule out CAD, so not primary STEMI, primary angioplasty or STEMI Caths, or restenosis Caths. These are about 20% of cath lab volumes. 400,000 patients, only 38% had obstructive disease. 62% had no obstructive, or for that matter, actionable disease. And I'm sure that when you propose a cath to your patients, you don't tell them that their possibility of having the disease you're worried about is a coin flip. But in fact, it's worse odds than a coin flip. And in fact, these results are very consistent with Bayesian principles. Given the very low prevalence of CAD in the tested group and the non-invasive test performance, a positive result is much more likely to be a false positive than a true positive finding. And so is this testing accuracy that's a problem, or are we sending patients for testing who don't belong there and therefore skewing the data? It could be both. This caused such a stir that we repeated the analysis 5 years later because nobody believed it. And we got essentially the same result here. Over 600 patients, almost 700 patients, 58% had no obstructive disease, a little bit better than 62%. Only two-thirds had a non-invasive test pre-cath. Most of these were abnormal, but only a very small number were high risk. And that was the only predictor of test results that predicted the presence of coronary disease. Intermediate positive, low positive, and negative test, and no test, all hovered around the population cohort average of 40%, 42%. So with no improvement in the C statistic. So then the question is CT, so obviously stress tests are not that great gateway to the cath lab. Is CT any better? We've talked about false positive and negative results. Here's what, here's the data I just showed you. First NCDR study, second NCDR study. The VA crept past 50% in their study. In PROMISE and a sister trial very similarly constructed to PROMISE, in the stress test usual care group, both under 50% prevalence, again, coin flip. However, in the CT arms in both of these trials, you see that we approach 70–80% prevalence of actionable CAD at the cath. And I'm sure there are interventionalists listening who are going, yes, because I really want to spend my time fixing lesions and not doing diagnostic caths where there's no disease. And in fact, this value of CT is underscored in the intake information in ischemia. So the primary question, of course, you're all familiar with, which is medical therapy versus revascularization. But looking at trying to how to understand anatomy and physiology relate in the eligibility for ischemia testing gives us a lot more information about how CT performs versus stress testing. So this is before you could be randomized down here to the two arms, you had to be a stable patient. You had to have moderate to severe ischemia on a functional test, not only as determined in the site, but determined by the core lab. So there was no quality issues here about determining this. And then everybody had a blinded CTA to exclude left main and to make sure that there was an eligible lesion. And so everybody had that. And in fact, and it was read by a core lab, but blinded to the clinicians. In fact, 32%, a third of the patients, were excluded as screen fails from that CTA. These are people with core lab read moderate to severe ischemia on imaging stress tests. 2/3 of them, or 20% of the entire population, had no obstructive disease. A quarter of the protected left main, which of course and a few had other sort of random things. And then in a subsequent paper, they tried to say, well, what predicts left main on the stress test once you have moderate to severe ischemia? There are few parameters on the stress echo and a stress ECG which were weakly predictive of left main, but none on the nuclear test. This is the direct quote from most patients with moderate to severe ischemia. Ample imaging is needed to rule out left main disease. So you've heard a little bit about different tests, but let's talk about event prediction. Does this work well with, predicting disease is one thing, but predicting outcomes is really more important. So this is a slide from the PROMISE data comparing the CTA arm and the stress arm. Remarkably similar test positivity rates, remarkably similar hazard ratio for events in those with a positive test in red versus a negative test for obstructive disease. So all good so far, but then when we look at where the events lay, because so many patients, right, 90% of the patients had a negative test, even though the hazard ratio was 3.5 or 4, 64% of the events, as it turns out, in each arm, it's not a typo, of the events were in patients with a negative test. Because again, this population is so large that even though this group in red is a higher risk, this overwhelms that higher risk. And part of that is related to non-obstructive disease. And our PROMISE data here on the left, people with no disease is the bottom line. Those with lumpy bumpies, 1 to 49% have threefold greater event risk than those with no plaque at all. And here's single and multi-vessel disease. Similar data are in CONFIRM, looking here at all-cause death in the same non-obstructive categories. Not present is this top line, and you see survival gets continually worse depending upon how many vessels are involved or how many segments have plaque. So there's a lot of information that's not available on a functional test that is available on a CT about non-obstructive disease that's very important prognostically. So in here, talking about image acquisition, image interpretation, results communication. I'm not going to talk too much about that, but I will talk a little bit about non-invasive hemodynamics, invasive and non-invasive hemodynamics, and how FFRCT is helpful, and this is where the heart flow data come in. This is a slide from FAME data, which talks about how coronary physiology and coronary anatomy are not very well matched. And so we normally think of a diameter stenosis, bad greater than 50, good less than 50 in our minds. But when we add an invasive FFR, so flow wire data, we see that there's a lot of discordant patients on both sides of that 50% line. So these orange dots are all people who have a positive FFR, in other words, hemodynamically significance despite non-anatomic significance or anatomic non-significance. Here, these are people who look anatomically significant but don't have flow problems. And so the survival curve, the event-free survival curves here over almost 2 years shows that FFR does a better job of sorting out patients. The green and the blue run together than does a stenosis. Which really, we would expect to see the red and the green running together as stenosis were the arbiter. So this is invasive data, which tells you that just seeing the stenosis alone is not enough. Now this is flow wire, so everybody had to be in the Cath lab. HeartFlow and others have created a way to measure coronary physiology non-invasively. It's for FFRCT. It's a big data approach using machine learning and supercomputers to create finite element flow dynamic models of the coronary circulation from a standard CT. It doesn't require fancy acquisition parameters. It can be done on any existing image set. And then it simulates different hemodynamic states to come up with FFR CT numbers that are very analogous to the invasive flow wire data with a cut point of 0.8 also. And so you can see here, very nice, and it's color coded, so beautifully presented. Very, very tight lesion here, and the FFRCT drops from 0.97 to 0.56. For the first time, this was included in the guidelines as a class 2A recommendation for several uses in 40 to 90% lesions. So notice 40 to 50% lesions are included and 70 to 90% lesions are included in that. So it's not just the 50 to 70s. Vessel-specific ischemia as opposed to just a positive stress. ANOCA or ischemia without obstructive disease with persistent symptoms, often because you can find diffuse disease. And catheterization decision-making, which lesion needs to be addressed. And this was tested in the Pacific trial, which I like very much as a non-invasive person and an echo person. I'm used to sensitivity and specificity being compared to Cath lab anatomy, which of course is physiology anatomy. We already know they don't match. What's great about this study is two things. It's small, but what's great is that they used all the tests in every patient. So it's absolutely head to head. It's not two different cohorts. And they use invasive FFR as the gold standard. And the per vessel AUC was dramatically higher for FFRCT than it was for PET or SPECT. So we started working with FFRCT about 6 or 7 years ago, and this is the first study that I published on the platform study, again, supported by HeartFlow. And this is an observational study, and we did sequential cohorts with clinically planned Cath. So we had patients who had a Cath ordered, and we sent them to the Cath lab as is. And then in the other cohort, we added essentially a drive-by CT with FFRCT. So on their way to the Cath lab, we detoured into the CT lab, got a scan, and as a result of that scan, 61% of those planned Caths were canceled. Huge change. As a result, the rate of non-obstructive disease fell from 73%, which is quite high, to a very nice 12%, with no impact on safety or CAD detection, and of course, a very nice cost savings. So here's the diagram: usual care, 73%, no obstructive disease, a red finding, obstructive disease here at 27%, exactly the same in the FFRCT guided Caths, but the no obstructive disease fell to 12%, and of course 61% had their Caths canceled, saving that cost, time, and expense and risk. Here's a meta-analysis, which is just out now in Heart, looking at 5 or 6 different studies, looking at event rates with against a cut point of 0.8 for an FFRCT. And you can see all events, death, acute MI, spontaneous MI, all predicted better by FFRCT at that cut point by 0.8 versus the other cut point. And there's a bit of a dose response curve here. And so comparing a FFRCT of 0.9 to one less than 0.6, you can see the benefit, and you can see that gradually comes down to 1 when you get over, and crosses the line here when you get over 0.8. So some population benefit. So let's look at outcomes. Now, you've seen this arrow throughout the talk. Another way of looking at clinical outcomes, which is done in the radiology world, is to look at a hierarchy of parameters, starting with technical capabilities like pixel size, say, or temporal resolution. Diagnostic performance is sensitivity and specificity, likelihood of changing a diagnosis, reclassification would be diagnostic thinking. And most of the time we end up in this area when we're talking about a non-invasive test. But if you push it, does that diagnostic test change how you think about therapeutics? You know, are you going to an invasive strategy or non-invasive strategy? And then does that actually happen? What is that strategy, of course, which can very much have an impact on outcomes here in clinical outcomes. But you see that this is linked. So you can come to this clinical outcomes and imaging, either from an imaging perspective or a quality perspective, but you end up at the same place. So let's look at these better patient care and better outcomes. And let's look at plaque detection, preventive treatment, and invasive therapy. So the ischemia trial. So we talked about plaque detection in PROMISE and CONFIRM, and I already showed you that. But here's a slide from the ischemia trial looking at outcomes by ischemia severity, all-cause mortality, myocardial infarction, primary endpoint. I just realized I've been pointing to the wrong screen, by ischemia severity and CAD severity. And you can see here, all the bars cross one in terms of risk. So no category of risk, severe, moderate, or none, changes our ability to predict mortality MI or the primary endpoint. Whereas if we look at CAD severity by 3, 2, or single vessel disease or mild single vessel disease, we see a very nice prediction here in higher risk in the higher categories, the greater than 70% 2 or 3 vessel disease or proximal LAD. So suggesting that actually event prediction is related to better determined by CAD. And a similar study here in the CKD sub-study, the chronic kidney disease study of ischemia, which showed severe versus moderate here, some protection for ischemia, but not significant, whereas very dramatic changes in the hazard ratio here for anatomic disease. And you can see the very nice splaying of the curves here in the anatomic disease versus the ischemia, yes, no, really just the curves overlay each other. So what do we do when we have non-obstructive disease? We talked about that prognostically. Here's some data from CONFIRM, and it's observational data because there have been no, and I emphasize this, no prospective randomized trial of statin use in patients without obstructive disease. We have primary prevention trials and we have secondary prevention trials, but that gray zone of just plaque that we're learning about as CT becomes more common, we don't have any trials there. So we're stuck with observational studies. And here, this is 10,000 patients followed for 2 years. We can see that in those with no plaque, statins do not affect all-cause death over 4 years. And in those with non-obstructive disease, there's actually a 68% reduction in death using a statin over almost 4 years. So very powerful data to say, if there's plaque, you should treat it as a secondary prevention patient. Similar data can be gleaned from this study of 4,000 patients with diabetes, but no obstructive disease, who were followed up for 5 years for stroke, MI, or death. And those treated on aspirin, again, an observational study, had no benefit versus those who weren't on aspirin, but those who were on statins had a halving of their risk from 37% event rate to 25% event rate. Again, saying statins in non-obstructive disease in diabetics would be preferred over aspirin. So the final arbiter of outcomes is, of course, large randomized trials, and I'll show this level of evidence A in the new guidelines, reducing death in MI. So the first thing that happens with CT versus functional is that we get better preventive care. And these are data from PROMISE, and you can see in the CT arm, there's an increase in all forms of medicines, aspirin, statin, beta blocker, and ACE inhibitors. This is actually also significant. So substantially more preventive therapies, and the same in the Scott Hart. You can see CT had more new antiplatelet prescriptions and more new statin prescriptions compared to usual care. So the first thing that happens is intensification of needed preventive therapy. And I've started out with saying very much under treatment, at least in the PROMISE cohort. And Scott Hart, there's a really nice reduction in 5-year event rates, CV death MI or non-fatal MI, that is true for every single subgroup that you might find. It's a 40% reduction in risk, despite a similar Cath rate and revascularization rate. So it really can't be attributed to enhanced detection of disease. Caths were greater initially than in the CT arm, but the usual care arm caught up. So very, very positive evidence in support of CTA as the first test to improve care and also improve outcomes. And I'm going to, there are many more things that I could tell you, but I'm in the interest of time, we'll skip forward to say, well, you know, okay, so we have a lot of information here. How do we put this together into a strategy that people can use, right? So we've got all these 1A guidelines now. How do we put this together into improve outcomes? And we are currently completing the PRECISE trial, which is now in follow-up, is now just completed follow-up actually a couple of weeks ago, which we hope to present at AHA. And this is a 2,100 patient study supported by HeartFlow, with patients very, very similar to PROMISE patients, non-acute, stable patients with symptoms who are recommended for a non-emergent diagnostic test. And so we stratified the randomization by PROMISE risk score into a usual care evaluation, which the strategy was selected by the site clinician. It could be functional testing or direct to Cath, but we did not disclose the PROMISE minimal risk score here. They just did whatever they were going to do. So you can see low risk or high risk, all the same. To a precision strategy where the testing was assigned by the PROMISE minimal risk strata, and those in the lowest 20% of risk had no immediate testing. So actually we're prospectively testing the new guideline recommendations here. And those in the highest 80% of risk had CT with selective FFRCT if there was a lesion over 30%. We did have a couple of pop-off valves for safety. First, if there was known calcium score, known calcium coronary calcification on CT, we immediately went to, or vascular disease, we immediately went to a CT, figuring out even if those were low risk, that these were people that we would want to test on. And of course, this group who had no immediate planned testing could have care escalated at any time if the patient or clinician wanted it, if the chest pain didn't go away or got worse. And about 20% of these patients actually escalated in the trial. So 80% stuck with this no immediate testing. And our primary endpoint is an effective chest pain evaluation at 12 months, as measured by death or an MI, and a Cath without obstructive CAD. And this is measured by a QCA stenosis greater than 50% or an invasive FFR or IFR that are significant. So the absence of those with the hemodynamics trumping if they were available. We have secondary endpoints in hierarchical analysis of the primary endpoint. Denmark is doing an economic and quality of life analysis. We're also looking at preventative medicine use, radiation, and efficiency in the Cath lab in terms of prevalence in the Cath lab, in the patients that do get to the Cath lab of disease, and also the conversion rate into a revascularization procedure. So here in summary, what I hope I've shown you today is that using imaging quality domains can help improve the evaluation with chest pain patients. So starting with the patient, revised pretest probability estimates can improve CAD prediction and risk stratification in many ways, and can also be improved upon with risk factors. The new guidelines may improve care by elevating CT to a class 1, but may have some unintended real-world impact on excluding patients from testing. I feel that the PROMISE minimal risk score can help improve this decision about testing or non-use of testing, as it identifies half of those indeterminate 5 to 15% pretest probabilities who will have low yield testing. And this hypothesis is being tested prospectively in a randomized way in the PRECISE trial. So not just guessing here, but really want to prove this. And then CT, I've shown you, improves Cath triage and yield, and the FFRCT provides additional value in detecting events. In trials, CT enhances clinical risk stratification and elevates preventive care, intensifies preventive care more appropriately. And most importantly, CT first strategy has been proven to improve long-term outcomes. And so thank you very much for your attention and joining us today.
Thank you very much, Dr. Douglas. That was amazing. I think so much content and so many trials you've led just funneled into this presentation. I love the concept of non-obstructive disease and how we focus in finding that significant stenosis. And when it's non-obstructive, we still see a lot of patients undertreated for that. We just disregard them and they don't get the right therapies. So please put your questions in the QA. We'll go through them. I'll start with the first question. So you talked about imaging of non-obstructive CAD. What are your thoughts on FFRCT versus high-risk plaque features? Is FFRCT a surrogate for high-risk plaque?
That is actually a bit of a question still. It definitely, high-risk plaque features tend to cluster with a hemodynamic significance, but they're not exactly the same thing. And we don't know, I don't think we know fully yet which to believe when. For example, clearly if both are present, it's much worse than if neither are present. But it's unclear, at least the data that I've seen, prospectively mapping value from one approach versus the other approach. And I actually don't see any reason why you wouldn't do both. They're both able to be done in an automated fashion. There's several vendors that have automated plaque analysis right now. Small companies, Clearly is one, Jim Min's company, several others that take other approaches to it, like perivascular fat as another high-risk inflammatory proximal vessel fat attenuation. HeartFlow is launching a different package of analyses in addition to FFR, which is not quite out on the street yet, but will be very soon. And I think we're just starting to actually learn about coronary physiology. And I know it sounds kind of silly that we're 50 years into angioplasty and much longer than that into cath labs and cabbages. But we're just starting to learn now. I think we've done so well with the stenosis model. We're starting to learn now about not just discrete stenosis, but diffuse stenosis, about volume mass measurements. Is the actual volume of the coronary sufficient to supply that massive myocardium, completely separate from stenosis? Plaque, as you mentioned. So there's just a lot of aspects of coronary physiology and anatomy that we don't routinely consider in clinical care, but I think are very important. And I'm a big proponent of a new CAD taxonomy, basically, that includes all of these things. You know, when we look at cancer, we talk about the tumor, the nodes, and the metastases, and maybe we need to talk about the stenosis and the hemodynamics and the plaque and the diffuse disease when we fully analyze a patient with coronary disease.
Thank you very much. We have a question from Mark Menegos. He says, I worry, especially with Cularis paper, American guidelines, that the value of clinical history is being even more undervalued and sends a bad message to our trainees. What are your thoughts on that?
Interestingly, this is a very interesting question. And we want to, and we need to know more about it. The prevalence of typical angina in testing populations has declined dramatically over the last 20 to 30 years. And the Cedars-Sinai nuclear cohort is a really good example on that. And so what we all learned when we trained, or when I trained, maybe you're younger, you did learn differently. What we learned about the importance of typical angina doesn't really exist anymore in the same way. It's only about 10% of patients. And it doesn't seem to affect things as much. We just published a paper, Angela Lowenstern just published a paper on this in Promise. It doesn't seem to affect risk in the same way that we think it ought to. And so there's a reassessment going on here. What I do think shouldn't have happened is lumping the very non-anginal chest pain patients' prevalence of disease with those with typical angina. So that I think is a concern. And I saw flash up on the QA, Mike Nana Jr., I guess, I didn't know his father's name, was a fellow with me when he trained at Duke. He's now at Yale, and was the Promise and the Precise Fellow during that time, and contributed enormously. So shout out for your son. He's awesome. Contributed enormously to this work and particularly the Precise study, and has stayed very engaged since, and will be part of the Precise team. Actually published the Precise, was first author on the Precise methods paper in AHJ.
Great. And what do you think about the risk factors? We usually just mention risk factors as a yes or no, but we never talk about the control, if the risk factors are controlled, if they are modifying therapies, and we use a cutoff just to decide PCI or not without taking into account these agents. How do we incorporate that into trials?
I think that's where the art of medicine comes in. Now, the AHA-PC, algorithms do talk about blood pressure control, for example, and treatment versus untreated blood pressure, and so there is something there, but we don't have good population-based data for different levels of control of risk factors. Does a statin at 130, an LDL 130 or 100 or 90 or 70, what does that mean? We do know that 70 is probably the right target, but we don't, putting that in a quantitative way, we don't have that. That's what the gestalt from a knowledge and experienced clinician would bring to the process.
And do you think progression of disease could be a next target for therapy? Do you think progression with CT or with plaque analysis? What are your thoughts on that?
I think that's really important because we really need to know, for example, if CT is a good surrogate endpoint in trials. So if we wanted to do a trial on patients with non-obstructive disease, for example, we would need an enormous population followed over many, many years to know whether statin treatment was beneficial on that. And in fact, NHLBI has had that trial proposed. Phil Greenland and others have proposed that trial many, many times over the years, but it's just too expensive to do. But it's a trial we really need the answer to, right? We really need to know that information. And so if we could use CT change over time as a surrogate endpoint, that would allow us to, study people quicker, so shorter trials and perhaps fewer people, the added costs of the CT. But we don't know enough yet, I think. We have only a handful of trials that have done serial CTs. Matt Budolf has led some of these. And the changes in CT are complex. So statins may increase calcification, in fact, which may be a good thing. It may be plaque stabilizing. But we certainly wouldn't want to use calcium score as a therapeutic endpoint because it may go up as a benefit instead of down. And so I don't think we're ready to design that trial yet, but I think it will come.
Thank you. Thank you very much. This was an amazing lecture, and I think it will help. It helps us all to understand where we are in the field and also our patients with more treatment for non-obstructive CAD. So thank you very much.
You are most welcome, and everybody